Hi, thank you for joining us for LGBTQ Inclusive Care, Pride in Health and Wellbeing. My name is Phoebe James and I'm a Professional Development Officer with the Primary Health Network. Before we go any further, I would like to acknowledge the traditional custodians of the land we are all meeting on today and pay respects to elders past, present and emerging. Just wanted to mention before we start that this session is being recorded. The recording and the PDF slides will become available on the PHN website in the Education Library in the next few days. We are having a quick Q&A session at the end of the presentation, so please feel free to put your questions in the box and we'll endeavour to get to all of them. There will be an evaluation at the end of the session also, and I would love for you guys to fill that out, please. Tonight, we are very lucky to have Claire Allen, who's the National Program Manager of ACON's Pride in Health and Wellbeing program. She has worked in a variety of roles and brings with her a wealth of experience in LGBTQ inclusion, change management, project management, and organisational enablement. I will now hand over to Claire.
Thank you so much. Let me just share my screen. Excellent. So as mentioned, my name is Claire Allen and I use she, her pronouns. I'd also like to acknowledge the traditional owners of the lands that we're meeting on. I'm on a Awabakal and Worimi lands, and I thank the owners for their custodianship, because without them we wouldn't have such beautiful lands to work, live and play upon. I'd like to pay my respect to elders past, present and emerging, and all the Aboriginal and Torres Strait Islander people joining us today. Let me just try and change my screen. Is that one any better, Phoebe? Excellent. So I want this to be a safe space for everyone. Please ask me any questions that you probably couldn't or shouldn't ask your LGBTQ colleagues, and definitely not your patients. There's no such thing as a wrong question, so please approach this with respectful curiosity. But be mindful that we all do have different lived experiences, and be mindful of anyone that might be hearing over your shoulder as well, because some of this might be a little bit uncomfortable. If it does raise any emotions for you, please feel free to step away from the training, or if you're anything like me and it bubbles up at 2 in the morning, please reach out to one of the contact lines that are available on the screen, including some LGBTQ specific contact lines. So today, what we want to do is have a look at why LGBTQ inclusion is really important, especially across the health, wellbeing and human services sector. We want to explain the differences between sex, gender, and sexual orientation. All right, now hopefully you can see my screen properly. We want to look at some of the unique challenges for the LGBTQ people and respond to some of the questions around that. And look at the barriers people face in accessing healthcare specifically, and the health disparities that become as a result of that. And then look at how you can create a really safe and inclusive space within your service. So I'm part of ACON. ACON used to be the AIDS Council of New South Wales, and back in the 80s, we were developed as a community response to community members living with HIV. Since then, we've grown to be Australia's largest LGBTQ provider and have expanded out of just HIV support into all sorts of support, including trans health equity, disability support, aging, mental health, sexual health, alcohol and drugs, domestic and family violence, and a whole lot more. Since then, we've also grown to include services for mainstream organisations, because we realised that at ACON, we can't do everything for our community ourselves. We needed everyone to be more inclusive. So the Pride Inclusion programs were born. Pride in Health and Wellbeing, looking at the health sector, Pride in Diversity, looking specifically at workforce inclusion in the commercial space, and Pride in Sport, looking at everything from grassroots sporting organisations all the way up to the Olympics. Everything we do is evidence-based, best practice and person-centred, and we are national and a member-based organisation. So we offer all sorts of support to health and wellbeing service providers. We run an annual conference, we run a free national benchmarking tool, and we can help you with your policy process forms, training, consulting, affirmation support, and a whole lot more. So why? Why do we need to talk about LGBTQ inclusion? It's 2022, we got marriage equality votes 5 years ago, so why are we still here? Or also, we have no complaints, or we have no LGBTQ patients, or surely we're just talking biology, which is male or female, right? Hopefully by the end of today, you'll be able to understand why some of these are not valid arguments and that we all need to be more actively inclusive. So why is LGBTQ inclusion important? Well, whether we think about it or not, every single one of us has a sexual orientation and a gender identity, but we're in the privileged position to not have to consciously think about this on a daily basis. But for some people, they do. They have to consider what clothes they're wearing before they leave the house in case they get misgendered. They have to hide parts of their family or loved ones in fear of outing themselves. Even something as simple as the phone photo that you use on your background, you need to think about that in case the notifications come up and it accidentally outs you. So we are very privileged, but we all have a sexuality and a gender. We don't want anyone to have to keep that hidden. But more than that, what we want to do is remove the barriers that the LGBTQ community face in accessing care. And by doing that, hopefully we can reduce some of the health disparities that the community also face. We want to normalise the discussion around sexuality and gender and really create space for visibility and remove the taboo nature of these conversations. And at the end of the day, what we want to do is know who's sitting in front of us so that we can give them personalised, person-centred care, which is the goal of all our care. So each year we put together an infographic of the statistics, predominantly Australian and predominantly from the prior 12 months. And you can access them using the QR code on the screen. As you'll be able to see, there is great health disparities for the LGBTQ community, but it's not just mental health or alcohol and drugs, it's across great measures of psychosocial wellbeing, including homelessness, preventative screening, access to support services, number of people living with chronic health or disability. So we can really see that there is a significant gap in our provision of care for LGBTQ communities. And we don't want that to be the case anymore. So what we want to do is move away from this concept of equality, where we give everyone the same thing and expect them to succeed, and move to a place of equity, where we give people exactly what they need in order to succeed. Because we are individuals, we don't need the cookie cutter approach. And a bit like the ramp and the pitch chart, we need to have these supports in place before someone uses our services. Otherwise, they won't be able to access us. And because we're talking about workplaces here, we're talking about our behaviour in our workplace rather than necessarily a change in beliefs. It's about providing you all with awareness and understanding so that you can create an environment that is more inclusive, rather than accidentally excluding the LGBTQ community because of those barriers that you aren't aware of. It's about creating that safe and caring environment where hopefully people will feel free to disclose, but it's not a tick box exercise. So we're not trying to get the most number of ticks as we go. So here's a video for you. Sorry if the sound didn't come through properly. I'll put the URL in the chat at the end, but that was as loud as I could make it, so apologies. What that video did show us, and even though it was a little bit silly, is that there are many reasons that people may not show their complete identity. It could be because of their culture or their faith, or the fact that they're a carer or parent, or their sexuality or their gender. And for many people, they're minority identities, and we don't want anyone to have to hide their identity. So while we're talking about LGBTQ inclusion, a lot of the same themes are true for other minorities as well. So what we want to do is move from tolerance to acceptance to inclusion. So tolerance is really hating what you're doing but putting up with it. So it's really, really negative. Acceptance is probably really passive. So come, go, it's no different to me. Inclusion is the state we want to get to. And inclusion is an active doing word. You can't be passively inclusive. You need to invite people in, let them know that it is a safe and affirming space. So we want you to be actively inclusive. But beyond that, what we would also like to see is move to a space of belonging. Instead of inviting people into your space, create a space where everyone is owning and belonging there. So taking away those barriers. So we've talked about LGBTQ and LGBTI, and we talk about the group as a bit of a homogenous group. So let's break down who's in this group. We have lesbian, gay, bisexual, which is talking about our sexual orientation, who we're attracted to, either romantically or sexually. T is for trans or transgender, which is around our understanding of gender and its relationship with the sex we're assigned at birth. And we have intersex status, which is talking about our body. So really quite a different group of people. And for most of us, what we are is we conform to the heteronormative binary, and that's represented by the pink and the blue lines on the screen. So for some people, they're assigned male at birth, they grow up to be a man, they're a masculine man, and they're attracted to women. Or conversely, they're assigned female at birth, they grow up to be a woman, they're a feminine woman, and they're attracted to men. And our systems and our society reinforces this. So if we think about gender reveal parties, baby showers, toy catalogues, kids' clothing options, fairy tales, pop culture, society more broadly, they really reinforce this heteronormative binary. And if you look at the language behind that, hetero meaning heterosexual, normative meaning the norm, and binary meaning the two options. But we know it's not innate, that you don't start as being assigned male at birth and everyone follows that path. So we need to look at these parts of our identity individually, and rather than assuming that these are the only two paths for people. So sex assigned at birth, we have male and female, and we're pretty comfortable with those options. But we also have people living with intersex variations. And these are a group of variations that are present at birth, but might not be picked up at birth. So it can be anatomical, chromosomal, or hormonal. And if it's not picked up at birth, it often presents at puberty, or when trying to conceive, or even as late as menopause. And it's where the parts of our body and our sex characteristics don't fit into our medical norms of male or female. Here at ACON, what we have done is signed a statement of human rights written by people with intersex variations called the Darlington Statement. And in that statement of human rights, there's a statement that says all training around intersex bodies should be led by someone with an intersex variation. And we wholeheartedly agree. So that's probably as much as we'll go into around intersex variations, except to point you towards Intersex Human Rights Australia and Intersex Peer Support Australia as the two peak bodies within Australia around all things to do with the intersex variation umbrellas. But it's about 1.7% of the population are born with an intersex variation, so not as rare as we think. It also shows the natural diversity that already exists outside the two binary options within society and nature more broadly. We even have a concept of 3 sex characteristics on our birth certificates. So while in New South Wales you can only pick M or F on a newborn, we do have this concept of an X gender marker, which is indeterminate, intersex or undefined. Pretty sure no one's undefined, but it's a bit of a catch-all that the government's put together. So again, we've got more than 2 options. But in New South Wales, as I mentioned, you can only put M or F on your baby's birth certificate, and that's purely based on anatomy, whether someone has an innie or an outie. X can be put on retrospectively, but in New South Wales, you currently have to have undergone some sort of medical affirmation before you can update these details. Gender is our innate sense of self, and there's no minimum standard that you have to achieve in order to be your gender. And no way you can look at someone and say what their gender is. So we have the binary genders, so man and woman, male and female, but also non-binary genders, and that's someone who sits outside our constructs of male and female. And it's more like a mosaic than a spectrum. And so some people have no gender relationship, some have a fluid gender relationship, and some people might have an identity that sits across both binary and non-binary genders. And the important takeaway for you is not that you need to know every single gender option that's out there, but be aware that people might identify in a way that's different from the sex assigned at birth and in a way that you can't necessarily see. And then we come to gender experience. So the T in LGBTI or LGBTQ is for transgender. We've also got this language around cisgender, and that's a newer term. So cisgender is the majority of us on this call. It's someone who identifies as the gender that matches the sex that they were assigned at birth. So most of us are cisgender. Then we have transgender and gender diverse. It's someone whose sex and gender are different. So trans meaning across, they've jumped across those heteronormative train tracks, cis meaning on the same side as. And the reason we have this language is not to complicate things, but so we don't stigmatise the language around trans people, because we used to say things like normal people and trans people, when really we mean cis and trans people. And that way we can describe a whole room of people without using that stigmatising language. And we're not othering anyone. And like other options, gender has a lot of language that you don't need to be an expert upon. And the language is changing as people find their language to describe their understanding of their gender. And then our gender experience, so that relationship there is cis or trans. Gender affirmation. So this is the process that we used to call transition. We're moving away from that language now because transition indicates a change, whereas affirmation is really about celebrating the gender you always were, but didn't necessarily celebrate externally. Gender affirmation usually occurs in these 3 broad categories, but there is no, again, right way or wrong way to affirm one's gender. It's not a linear process, and there's no minimum standard. So everyone's gender journey is very, very unique. Social affirmation usually occurs first, and that's because this doesn't require anyone's input apart from my own. It's also really risky because this is the first time I'm coming out as my true gender. So I might change my name publicly, change my appearance, use different pronouns. And there's no right way or wrong way of doing that. Medical affirmation can include things like taking hormones, having surgery, both top and bottom surgery, and also other gender affirming procedures such as speech pathology to change the timbre of your voice to match your gender identity, or even things like hair removal. Again, medical affirmation isn't what everyone wants. Some people are completely happy with the body that they've got. Other people can't achieve medical affirmation because a lot of the procedures require some sort of payment or out-of-pocket expense. And for a lot of people, that's not achievable financially. A third group of people can't achieve medical affirmation because of coexisting health conditions that mean they can't take the hormones that they want to take or have the significant surgeries that they want to have. The third type of affirmation is legal affirmation. And the reason that this is usually the last type of way of affirming one's gender is because in New South Wales especially, you can't update your legal documentation until you've had some sort of medical intervention. If you don't have medical intervention because you can't or because you don't want to, then you can't update your documents, which for us as health professionals provides a really logistic conundrum for us, because we've got individuals here that could have bodies that don't match the gender that we are assuming, whose legal documentations don't match their identities and perhaps not their bodies as well. So we need to treat people as an individual and not make assumptions about their bodies, about their identity, or about their legal documentation. Then we have gender expression. So these are the outward trappings and the social norms that we might show based on our gender. And we're pretty good with masculine and feminine, and David Bowie has taught us about androgyny. But these really change over time and depend on the era that we're in. So if we have a think back, if we were in the 40s, I'd be in so much trouble because I'm wearing trousers, not a skirt, and stockings and heels. I'm working. That's also problematic for someone that's female. I'm not wearing my hat or my gloves. So that would be a gender expression norm from the 40s that is not there today. But we also know clothes are clothes, and they can be performative, such as in drag, or artistic, like Harry Styles being on the cover of Vogue in a ball gown, or they could be related to our role. And as women move into more male-dominated industries, we're seeing women presenting in more masculine, traditionally masculine attire. So have a think. If we all go out for dinner after this and we found a man in a skirt and stockings and heels, would we think they were particularly masculine in today's society? Probably not. But if we have a think, skirts or kilts or sarongs or lava lavas are very masculine in the Scottish and Pacific Island cultures. And if I was a male French aristocrat in the 1700s, I would be wearing wig and makeup and stockings and heels. So it's very much culturally dependent, as well as the era that I'm in as well. The takeaway for you though is that I can't make an assumption on someone's gender or body or pronouns based on the clothes that they're wearing, which takes away a shortcut for us. And then sexual orientation is the last of those four fields. And that's who we're attracted to romantically or sexually, or not at all. And we've got a concept of being attracted to a single sex or multiple sexes. And also the concept of asexuality, which is not having a sexual or romantic attraction at all. So we might be slightly more enlightened than we were 20 years ago when we'd nudge our nephew and say, have you got a girlfriend yet? Now we might say, have you got a partner? Because we're trying to be much more inclusive. Well, really, that's not so inclusive of those who are asexual. So we can just need to change our language to adapt to those differences that we might not be thinking of on a regular basis. And if you're all worried about stepping on people's toes, Don't. Ask them how they identify. That way you're not making any assumptions at all and you can't get it wrong. And then to understand the nuance of the language that they use to describe themselves, ask them, what does that mean to you? And then not only will you understand the nuance of that identity, but you'll also have it in context to the service you're providing to them as well. No assumptions, no mistakes. So there's a lot of words and it's evolving really fast, the language surrounding LGBTQ communities. And on here, there are some really bad no-nos. So things like normal, we don't use, because by saying one group is normal, we're implying that the other group is abnormal. Normally what we mean is the majority or cisgender people, in which case use that language because it's not stigmatizing or discriminatory. Lifestyle is also a bit problematic. It implies choice and often decadence. And those of you that can remember back to the 90s would remember that the gay lifestyle was a bit of a panic defense that was thrown around towards the community. So lifestyle we don't use around the LGBTQ community because of that prior triggering trauma. Preference is slightly trickier. So we don't have a preferred gender and we don't have preferred pronouns. It's just our gender and our pronouns. What we do have is the concept of a preferred name. Some people may have a shortened name, so prefer Ben versus Benjamin. Other people might have an anglicized name that they prefer to use. So we do have a concept of preferred name. And that's okay to use as long as you counterbalance it with, say, legal name, where you need to know those details as well. But don't be afraid of all the other terms on the screen. They're changing and they're evolving, and just be open to the fact that there is different ways that people might identify. Queer, however, is one I would say use with caution. So queer also is a reclaimed slur, and for many people it's very triggering in the way that it was used against them in the past. So it is being reclaimed, so a lot of youth especially are finding that it's a term that they want to readapt. So I would never call someone queer without them self-identifying, but I would absolutely reflect that back if that's the language that they use to identify themselves. So if you're ever in doubt, reflect the language that person uses. So which acronym is right? I've been using LGBTQ. A lot of the health literature uses LGBTI, and there are many other variations. So you might have seen LGBTQIA+, A for asexual. Some people say for allies, but I don't think so. Plus is a bit of a catch-all for all the other identities. And more recently, I've seen more acronyms with the number 2 in it, which is a North American First Nations term for two-spirited people, or S and B on the acronym, which many Indigenous Australian communities use to describe their trans population, sister girl and brother boy. It's not across the board, but it is gaining popularity in a lot of written literature. So the acronym is growing, LGBTQIA+2ISB. Where do we stop? It's also getting weaponized against the community as people say A, B, C, L, G, B, alphabet soup, rainbow soup, whatever it might be. And the other problem with the acronym is we're specifically calling out some identities, which means that we're not calling out others. And the whole point of inclusion is to call out everyone and not make them invisible. So the acronym is a shorthand, but it's not the greatest. So we recommend that you use terms like people of diverse genders and sexualities. And this is growing pace across Australia, as instead of LGBTQ groups, we see groups of DGS or something like that. So if you're writing formal documentation, I would say people of diverse genders and sexualities. Not immensely hashtagable. So for social and shorthand, I would use an acronym, but in longer policy, procedures, websites, I would use people of diverse genders and sexualities, including all genders and sexualities, and maybe say that you're using the shorthand of an acronym for simplicity's sake. So we know that most LGBTQ people actually are really resilient and have really good health and are really diverse and wonderful in their identities. And they are represented across all demographics, so all cultures, all faiths, all locations. We know they draw strength from within the community, and that pride and inclusion events creates positivity and really good mental health. We know they have loving relationships, so why are we talking about LGBTQ health today? Well, what we do know through our own data is that there's a 20% toll on people who are not fully out at work. So their productivity drops by 20% if I'm not fully out and feeling safe and welcome at work. Similarly, for our patients, if there's about 20% of our patients will postpone or delay care that they've already organised because of that fear of not being included. And this is because we're constantly having to monitor what's coming out of our mouth and whether we disclose, whether we're safe, and trying to preempt the reactions of the people around us. And that mental toll has a real impact, as you can see through the statistics, and it also impacts our physical health as well. So our experiences, be they discriminatory, can lead to poor mental health and physical health. Our experiences within the health system can lead to care avoidance, and that care avoidance means we have less preventative and primary health care, which leads to longer term health disparities. And the structural barriers that exist within a structure like the health system mean that our experiences aren't as good, which means we avoid care and have worse health outcomes. So being LGBTQ does not inherently make you unwell. Being in LGBTQ in a society that still stigmatises your identity and discriminates against you can make you unwell. And the barriers that I talked about within the health sector aren't just within the health sector. There are indirect barriers that are happening at a macro level and across society. So these are things around the narrative in pop culture. Are we seeing LGBTQ people represented in film and television and pop culture at all, or in a positive way, or just as the light humour, the slut, the villain, or some other negative stereotype? Can we see ourselves represented in society and in politics? We know that during the marriage plebiscite, the mental health of the LGBTQ community plummeted because they were having their private and personal lives debated on TV, on the front page of the newspaper, at the supermarket. They couldn't get away from this narrative of everyone discussing their lives. We know that there is a lot of invisibility, especially within the health sector, because we don't capture accurately gender or sexual orientation, which means I don't see myself represented in a lot of the population health data or outcomes data. And because of that, there's a lack of research and data around how medicines and best practice can impact the community. And as I mentioned, the health system is designed for the majority. Doesn't mean it doesn't work for minority identities, more that it's a bit like a bad pair of shoes. It rubs after a while, but where things don't quite fit my identity. So they're ones that you might not be as able to update. Direct barriers, on the other hand, are ones that you can really positively influence. These are the ones that happen within your service. So have you trained your staff? Do you have gendered services? I know as a cisgendered woman, I'm really not particularly comfortable walking into the ultra feminine space of something like breast cream. If I was a trans person or a non-binary person, that would be a huge barrier for me, even more so. The lack of suitable forms is really hard work for the community because we don't know exactly what information you are after and how that's going to impact my care. My past experiences with you or the health system more broadly, and consumers often see us, the health system, as one ginormous interconnected behemoth, will make me anxious about next time. So I might have had a really great experience with a GP and a rotten experience with a dentist, which means I'm likely to avoid dentists in the future. And that is not a reflection on you and your service. It's a reflection about our hesitancy to seek care and make ourselves vulnerable. Confidentiality is the other really, really big one. I might feel really comfortable disclosing with my clinician behind closed doors. How does that translate to our admin staff and to the financial team and to other clinicians for referrals? And think about in a smaller town as well. If I'm seeing someone that is openly part of my community in a clinical setting, having confidence that anything I tell you behind closed doors will remain behind closed doors can be really problematic as well. And the last thing we need to think about is intersectional identities and how this can really impact our feeling of safety. So this map was printed in December 2020, and you can use the QR code again to access that. But what it shows is laws around the world around sexual orientation. The darker blue the country, then your sexual orientation is protected under law. The darker red the country, then your sexual orientation is actively discriminated in the law, with the darkest red meaning the death penalty for being sexuality diverse. So you can see Australia is not as dark blue as it possibly could be, and that's because our state and federal laws still aren't harmonised, and there's slight loopholes between the different jurisdictions. But if I come from a country or have family that identifies with a country in the red or orange areas, then I might be really anxious around disclosing because everyone's told me it's illegal or that there are consequences if I disclose. And so I also might not have the support of my family, my culture group, my faith group, that other parts of the community might lean on and lean into for social support. So while it still might be taboo to discuss sexuality and gender with people from international countries, we need to really make sure that we're wrapping around supports around those, especially from those red countries, because they might not have the other support mechanisms that are in place. And we also need to look internally. A lot of what we say and do comes from years of habit and experience and stereotypes. So if this person was to walk into our service, how have we addressed them? And what about now? Nothing's changed except for shoes and undoing a couple of buttons. Yet our whole perception of this person's gender has changed from a very masculine to a feminine one. And that will mean we're more likely to call them him or her when addressing them. And don't be ashamed of those natural instincts to go with him or her. It's our conditioning for all of our life. We have been told the shortcut of reading people's clothes and assuming their gender based on their clothing. Instead, if you're aware of the fact that this is an assumption you're making, you can avoid it coming out of your mouth. So the person on the left becomes the person in the boots. The person on the right is the person in the beautiful heels. And that way we don't make assumptions or mistakes about someone's gender. Forms, of course, is the other really tricky part of the process. And it's often the first point of contact we have with new patients as well. So we haven't had the opportunity to talk with them and show them how wonderfully inclusive we are. We also have got into the shorthand of asking one question: what's your sex or what's your gender, with an M or an F option only. And from that, we make assumptions about someone's identity and how that person wants to be addressed. We might extrapolate that out to their Medicare details so that we're paid and what's happening on their legal documentation. And we might extrapolate out to what's happening with their body and make assumptions about what organs they have. But really, they can all be really, really different things for some people. So best practice is to ask people to self-identify, but be specific about what you're asking. So when I say, what's your name? We need to say, well, hold on, am I asking legal name or am I asking how I want to be addressed? If I'm asking what your gender is, are we saying, is this so we know what pronouns to use? Or is this so we know whether to give someone a cervical screen? Or is this so they match with Medicare? And they will be potentially 3 very different questions. And it's okay to ask 3 questions because you know that there is a different need and a different outcome for that information. So what we do at Pride in Health and Wellbeing is help you with all of that. So we help you with your marketing and communications. How do you let the community know that you are inclusive? The community is very self-aware of safety, and so will often do their own investigation before even walking through your doors. So what does your website, your brochures all say about you as being inclusive? Can I get any indication of my safety from them? What about your intake and assessment? So when I walk to the doors and into your reception area, what does that look like? How is that telling me that I'm going to be safe and welcome and included? And more importantly, what do your forms say? Because the values that you put on your form and the options and the language you use will give me a really good sense of whether you're likely to be inclusive or not. We look at confidentiality and data management. A lot of the time, the systems are not as massively inclusive as we would like. So we ask things in a poor way because that's what the system is expecting. What we can get into the habit of doing is updating our forms and treating our patients as humans and then hiding the non-inclusive systems from them. But we know that we need to match with government agency databases in many instances, so working and advocating to them. So we've worked with Medical Director and a few of the other GP patient systems to make changes with them. How do you consult and engage with the community? We are a 40-year-old community-led organisation, so we act as a proxy to the community and direct community consultation, but we can also help you establish ways of communicating directly with the community through feedback, through consultation committees, through consumer reps, whatever works for you. That's usually slightly more mature once you've established the fact that you are being thoroughly inclusive and that you've established that trust. We work with staff. We do lots of training online, in person, and we tailor it to you and your particular part of the sector. We look at referrals and stakeholder engagement. If you're referring to another service, how do you refer people? What information do you share? How do you get their agreement this is something that you can share? A lot of people, especially the trans community, find that they are in letters, so referral letters, their dead names, which is the names they're assigned at birth, so their legal name is used rather than their affirmed name. There's not necessarily an indication of the pronouns they use or where they're up to in their affirmation journey. Or it's all put in there without their consent, which leaves them at a risk too. We also look at that through a risk framework. So do you have a list of service providers that you commonly refer to, and have you done an assessment on whether they're inclusive so that you've done your due diligence before you refer an LGBTQ person to another service? And we also work to embed this across your continuous improvement program. So it's not a one-off set and forget sort of flag raising ceremony, and it's not one person's role and it goes if they leave. We help you embed it across everyone's role as part of business as usual, but also how you keep up to date with best practice. So here's another video. Hopefully the sound on this one's a bit better. Apologies again for the sound. We'll make sure you get the URL for the two videos once we've finished this and go into the Q&A session. But hopefully you were able to pick up that a lot of people have really bad experiences with health practitioners. And if we see health as a big behemoth, my previous experiences are going to mean that I am going to avoid healthcare in the future, which means I'm going to miss out on my preventative screens and my primary health care. And when I do present, it's going to be significantly more acute than someone that has had that continuous ongoing preventative health care. It also means you need to be loud and visible and vocal about your inclusion so that, as Pat said in the video, we can overcome our own prejudices about the healthcare system and really give you a chance to show us how inclusive you can be as well. But it also showed we can't make assumptions about people. We need to understand and listen to our patients, which seems really obvious, but because of the strength of the societal pressures and the heteronormative binary and that narrative that infuses absolutely everything, we can sometimes fall into the habit of making assumptions about people rather than letting them self-describe. This is also a really tough statistic, so please take some self-care if you need to. 48% of trans young people have attempted suicide. That's 1 in 2. And that's a really hard statistic to try and get your head around. But on the plus side, that can be reduced by 82% through social support. That can be family, loved ones, friends, school, social supports, and of course, medical supports as well. And by doing something as simple as using a trans person's affirmed name, so their preferred name, not their legal name, we can reduce depression by 71%, reduce thoughts of suicide, and reduce suicide attempts significantly. So we could literally be saving lives by using someone's affirmed name. And that's my challenge to all of you, is to take away from today, if nothing else, that commitment to use someone's affirmed name, irrespective of what the forms, the legal, the systems might say to us, because you will have a really huge impact on the community. And we do know that this can heavily impact mental health. Most people are fairly aware of the mental health impacts of being a stigmatised population. The community also use alcohol and drugs at much higher rates than the cisgender heterosexual population, and this can impact our health. We know that within ageing, there are significant risks for the LGBTQ community, especially in entering aged care. We know that elder abuse happens, all the standard forms of elder abuse can happen, but also there's LGBTQ specific forms of elder abuse, such as outing someone, removing access to community, withholding medications for HIV or hormones. And of course, there's the concern around how I'll be treated in a service, especially if this is my home or if I'm inviting community care into my home. And so what we do want to see here is those wraparound supports. Preventative health, as I've mentioned, is often missed. And some of that is because of poorer education. So some people were saying that a lesbian doesn't need a cervical screen because they're not having penetrative sex, whereas we do know that they're still needing cervical screens. And so that's not best practice currently. We also know that a lot of screens are of intimate body parts. And if I'm trans and don't have a great relationship with those body parts, that can be a step too far for me. And as I mentioned, walking into a breast screen, if I'm a trans or non-binary person, can be a really intimidating mental hurdle to overcome, let alone physical ones. So we need to make space for our LGBTQ patients, especially in those more gendered spaces. And those statistics are significantly worse if someone is trans or gender diverse. And that's because they're a minority within a minority. And so we know that there is much higher rates of poor mental health, suicidality, poor screening, homelessness, instability in employment, and more. Homelessness is another big one, not just for LGBTQ youth who get kicked out of home when they disclose, but also for our elders. Many of our older LGBTQ people didn't think they'd live through the HIV and AIDS epidemic, and a lot of their peers have died. A lot of LGBTQ elders do not have a biological family on which they can get support, both financial and emotional. So many LGBTQ elders are in unstable or insecure housing and don't know where to go for assistance. Domestic and family violence also occurs across the LGBTQ community, although often goes underreported. And with most services being very heavily gendered again, there's not a lot of talk or understanding around the forms of violence that can be used within LGBTQ relationships, and no support or limited support services to wrap around them when they do seek support. And disability support is another really big rate. So 39% of the respondents to the Writing Themselves In For report were self-identified as having a disability or long-term health condition. And so while it's not a causal relationship, we do know that there is a significant number of people with these chronic health conditions that, again, are avoiding care or seeking it extremely late. And there's a high correlation between trans and gender diverse people and autism. At this point, it's only a correlation, not a causation. So what can you do? On the upside, this is how we can make an impact, how you can make an impact and make your services much more inclusive. Attend training sessions, so you all get a gold star for attending today. Talk to LGBTQ people. A lot of this comes from a lack of exposure to the community, not being able to necessarily point to someone and go, oh, I understand your background, or I've heard your stories. Be very careful of Dr. Google, a bit like all the other warnings about Dr. Google. If you Google LGBTQ communities, you can go down some hideous rabbit holes. I'd recommend that you look at reputable community-led resources like ACON or Pride in Health and Wellbeing, because they will give you lived experience rather than rhetoric. Read LGBTQ research. There is plenty out there. You just need to search and understand how this community may have different experiences from the cisgender heterosexual community. And measure your inclusion. You don't know if you're making a difference. You don't know if what you're doing is significant or tokenistic or impactful at all until you measure it. Acknowledge LGBTQ days of significance. So this Friday is Wear It Purple Day, which specifically looks at LGBTQ youth and their interaction with society and inclusion. So these days are not only great days to dress up and to celebrate the community, but they're also really good opportunities to do some accidental learning with your team about different parts of this really, really diverse and wonderful community. We have heaps of resources on our website if you ever have any questions around the days of significance across the calendar and how best to acknowledge and celebrate them. Be part of the solution. This isn't a job that one person takes. We need all of you to make change. So talk about pronouns. They're not as scary as we think they are. Advocate for inclusive language. Use that inclusion lens across your whole service. Look at the whole patient experience and say, what would the triggers and barriers be for me if I had to disclose my sexuality or gender or come here and be anxious? Definitely take a stand against slurs and jokes. Even in 2022, our own research through the Health and Wellbeing Equality Index has shown that there are significant levels of staff witnessing low-level slurs and jokes, as well as more targeted harassment against clients. Around 10 to 14% are still witnessing that. And that's in organisations who are actively working in this inclusion space. So we've still got a long way to go. And call out non-inclusive processes. Often the time we've used processes because that's the way it's always been done around here. But a fresh set of eyes, and for you to be the eyes and ears within your service, can mean that you can escalate where we can improve forms, where we can improve processes, where we can improve imagery, say. And we need everyone to be able to cast that lens over their service so that we can capture everything and make a change. I mentioned pronouns before. I introduced myself with pronouns. They're really not as scary as we make out to be. So by introducing yourself with pronouns, you're showing and demonstrating that you understand that there are people with different gender pronouns out there. You're also showing that you understand this and are possibly a safe person to talk to. But also things like putting them in your email signatures, LinkedIn profiles, Zoom profiles and things like that can mean that you are displaying this before someone has to ask you whether you're inclusive, and then it's that non-verbal way of communicating that you're an ally. So they, them, their pronouns. Some people use them as a non-gendered pronoun. They're not as tricky as we think, and we use them all the time already. So if someone leaves their mug in the tea room, they've left their mug in the tea room. I'll take it to reception for them to collect when they realise they've forgotten it. We do it automatically. when we don't know the gender of the person we're talking about. We put our foot in it when we see someone or assume someone's gender and then try and change what comes out of our mouth. So there's no easy way to work this out apart from practice. Practice, ask people their pronouns, see how they want to be referred to, and then mirror that back. And if you do make a mistake and slip, just correct yourself and move on. Don't make a big drama out of it, because while it might make you feel really icky and be a big deal for you, it's probably the 100th time that day that person's being misgendered. So they don't want to make it about you, they just want to be choosing the correct gender. So here's some inclusive options that you can slide into your language as well. So things like, hi, my name is Claire, I use she, her pronouns, how would you like me to refer to you? That can be a really non-threatening way to open the conversation up with people, displaying your inclusion through the use and sharing of your pronouns, but also means that Mrs. Smith can go, oh, you can call me Mrs. Smith, dearie, and not necessarily understand that we were asking other things as well. Ben can say, I prefer Ben than Benjamin. And for those who need to hear they, them pronouns, that will be the lifeline they're waiting to hear. So they'll go, oh, I'm Chris, I use they, them pronouns. Using non-gendered language like who's your next of kin, who do you turn to for support, means we're not making heteronormative assumptions. We're allowing for all different family structures, including kinship care, step-parents, grandparents, and more. Knowing and having to hand some LGBTQ support groups or referral services ready to go so that you can confidently give them to your patients when they need them is also going to be really important, as long as you've done your due diligence. And asking people and giving people the power back to discuss their body, especially after things like sexual assault, is going to be really important. So just something like, how do you refer to your body? Because some people will prefer medical terminology, some will prefer pet names or slang, and it really can take away a lot of the anxiety if we're mirroring the language that that person uses around their body, especially for the trans and gender diverse people who may have some dysphoria, especially with things like breasts and genitals. So just be open to other options there, and like I said, give the power back to the patient to help you make that decision. Be visible. Don't underestimate the power of symbols. The secret power of the LGBTQ community is the ability to see a rainbow a mile off, and that's because it's our signal of safety. We can see a rainbow because that shows us about inclusion without us having to put ourselves in a vulnerable situation and ask. And it doesn't have to be a formal rainbow flag or anything specific. It can be a rainbow set of building blocks from Kmart. And that's okay because it shows inclusion to the LGBTQ community. But it's great to promote yourself as an ally and why you're an ally. So say it proudly, share it on your website so people know who they can safely ask questions of. It's not saying you're an expert, just a safe place to ask questions and provide those wraparound supports. Share why you're an ally, because that can entice other people to go, oh yeah, my nephew's gay, I want to make a difference and make their life easier as well, if you're safe sharing that. And you don't have to be outside the community to be an ally. Even within the community, I can be an ally to a gay man because that's not my identity, but I'm going to support all aspects of the community. And as I mentioned, celebrate days of significance. And measure your inclusion. So this is a bit of a plug for our free national benchmarking tool. So we have a benchmarking index that's an evidence-based index on a 100-point scale. You send us your evidence via email. It closes on the 1st of February. We mark it against a really strict rubric, which we share with you so you know exactly what we're working on. And we give you your marks back at the end, along with a commentary about where you can make improvements. As part of this, and an optional part, you can also do a staff survey, and that looks at staff understanding for the need for inclusion, as well as the tools they think they've got available at the service, and then their comfort in putting those tools into practice. Because sometimes what we see is there's the greatest tools, but no one's actually using them because they're still anxious. They haven't quite got that change management and practice into place. And we also have a service user or client survey, and that looks at their fears and anxieties before entering the service and whether their experience matched their expectations. So really great ways to get feedback from your staff and your service users around what you're doing well, where your gaps are, and how you can make improvements. As I said, it's free and it's national and it's confidential. You can use the QR code to get to more information. The survey is open on the 1st of November, and all the index and both surveys close on the 1st of February. So I would say make use of this. It's a great free tool if that's something you're interested in doing. And they're my contact details. If anyone would like to get in touch, I'm happy to answer any questions, point you in the right direction. We also have a monthly newsletter so that you can keep up to date with events, best practice, research, books, podcasts, and more. We don't spam you, but it keeps you alongside what's going on if that's something that you're interested in, but not diving straight in yet. So now we might open up for questions because I believe there are a few. So let me stop sharing and we can ask some questions.
Thank you, Claire. So I had a few questions come through, which is great. If you guys want to keep putting questions in the question box, we'll get to them. All right, first question. Have there been studies on mental health, physical health of LGBTQ staff in healthcare in Australia?
We know a lot about LGBTQ staff in workplaces, not necessarily specifically diving down into health workplaces. We do know that there is a higher representation of LGBTQ people that are drawn to health and care type services. So we would say definitely an overrepresentation. I'm not sure that health is particularly good at supporting their LGBTQ staff. So I would say that there are big gaps there still, and a lot of health services don't know where to start. And they don't know whether to start with their patients or their staff. So they're sort of caught in this conundrum and get frozen with indecision. If you're tossing up whether to start with your patients or your staff, start anywhere. It doesn't matter. Some of it overlaps beautifully and some of it's very, very different. So we can help you with either of those, but I'm not aware of any specific research about LGBTQ staff specifically.
Okay. Have this question from Lisa. She's been looking for an icon or a badge that shows that the physio clinic she works at is LGBTQ inclusive. Can you recommend one that she can access?
Of course, ours. So we have an online shop that you can buy things like lanyards and badges for. Alternatively, there's something called the Welcome Here project, which is welcomehere.org.au, which is an ACON funded project where you can get stickers and transfers for your door to show people before they walk in the door you're inclusive, but you also get listed on a registry database of organisations that want to be known as being LGBTQ inclusive. It's $15 per site, and it's a great first step to say we're inclusive. What I'd just be mindful of is not putting up the sticker and not then training your staff and not having the other supports in place ready to go. But happy to help anyone with that if they want, or welcomehere.org.au.
Okay. What percentage of the population are LGBTQ?
Good question. Current stats are really hard to pin down. So the World Health Organization guesstimates about 11%, but to date there's been no really great survey of LGBTQ people because it really depends who's asking, how they ask, and how it's publicised. So unfortunately we missed out on the last census, so the next census should give us a good idea. And it also depends on generation. So if you were to ask a generation of over 65s, how many people identify as LGBTQ, you would probably struggle to 5%. You ask under 25s the same question, chances are it'll be closer to 20%. So it averages out between 10 and 15% of the population. And that's based on culture, safety, who's asking, where the data's going. A government agency versus, say, a community-led organisation such as ACON asking the question, will give you 2 different responses. So really hard number, but a significant number even at 1 in 10.
Okay. If someone doesn't have any LGBTQ clients, do they still need to be inclusive?
Absolutely. There's possibly a reason you're not seeing your LGBTQ clients. That's either because they're avoiding you because they don't know if you're going to be safe, or they're seeing you and not telling you because they don't think you're safe. So taking really positive, visible and vocal steps to show you're inclusive and not being tokenistic about it. So doing more than just putting up a flag, but training your staff, looking at your forms, looking at your policy, looking at your physical environment will mean you will start to see those LGBTQ people either stop avoiding you and come in, or disclose that they've been here forever, but you've just not seen them. So if you can't put hand on heart and say at least 1 in 10 of your clients are part of the community, then they're avoiding you.
Sure. Are there many LGBTQ diversity training workshops for healthcare professionals?
So we've got our program that we would absolutely recommend. Otherwise, ACON does a variety of workshops, online training modules. You can buy packages to host on your own learning management system and on a variety of health topics as well, from broad inclusion to sexual assault to trans affirmative care. We're doing one on cancer at the moment. So lots of really detailed health specific focus, yeah. So if you go to acon.org.au, pridetraining.org.au, prideinhealth.com.au, we can definitely help you out.
Okay, and just to find more information generally, where would you suggest people go?
A bit like I said earlier, avoid Dr. Google. It will lead you down some horrible rabbit holes. So go back to your community-led organisations, such as ACON, such as Thorn Harbour Health in Victoria, such as the LGBTQ Health Alliance, which is the national peak body, AusPath, who is the Australian Professional Association for Transgender Health. They give really specific advice around transgender healthcare from a clinical perspective, as well as the clinical standards. So yeah, be a bit discerning about how you Google and go definitely to community-led organisations.
Okay. We've had another question coming from Tyler. How to change the way some staff perceive LGBTQ members, changing the judgmental approach?
There's no one solution that works for everyone, and it depends where that judgment comes from. Often it's because of lack of exposure and a lack of understanding. We had this thing during there's a stereotype that people in regional and rural areas are less inclusive than city dwellers. And what we found through the marriage plebiscite was that that's not really true. What it came down to was a lack of exposure to the community and a lack of being able to say, well, Bob the butcher's gay, he's a good bloke, so I reckon I'm in, and not having that visible face of the community. And so where the more regional and rural towns did have someone like Bob the butcher, then they were really pro marriage equality. Whereas towns where it wasn't part of their lived experience or social networks, we were still seeing that hesitancy. So exposure is one, training is another one. The statistics around the why, the health disparities and the fact that there's a real need here from health services to improve their game is another one. Depending where you are in the health sector, if you're at federal or state level, the cost overhead for not working with the LGBTQ community at the primary and preventative level means that the acute care and emergency care presentations are going to be significantly more expensive. So there's lots of different levers. Some bosses especially love the fact that by being more visibly inclusive, we actually attract and retain more staff, both LGBTQ and non-LGBTQ staff, because we like their social justice values. And you don't lose those people, and you get better productivity, that 20% jump in productivity by being openly inclusive. So there's a real workforce need there as well. Some people are never going to change, and then you've got to ask them, is that the right fit for your organisation? Are they going to do potentially more harm than good if that's the attitude that they're giving to your patients? So different scenarios, different risks, but happy to work with you on any of those levers as well.
Okay, well, no other questions have come through, so I'll be able to finish up a little early tonight, which is nice. I just wanted to thank everyone for coming. It's in prime family time and dinner time and time to yourself time, so thank you very much. If I could just take a little bit more of your time to fill out that evaluation, that'd be great. And I wanted to thank Claire Allen, fantastic presentation, and I really, really enjoyed it. So thank you so much.
Not a problem at all. And if you wouldn't mind popping those 2 URLs in the chat. So apologies everyone for the video quality not being brilliant, but this way you get to enjoy it at your own leisure.
I'll attach them to the slides that'll be uploaded into the library, so that when you get the presentations, the PDF presentation slides, they'll have the URLs attached. All right, thanks guys, have a good night.
Thank you all.